Welcome, everyone, to this month's Lunch and Learn. We wanted to bring in a speaker today that would address perhaps the ripple effects of the LA wildfires that may be affecting your patients and families. I'm excited to introduce you to Dr. Sunday Okello, Division Chief of Pediatric Pulmonology at UCLA. As a pediatric pulmonologist and researcher, Dr. Okello is interested in improving asthma care for children, particularly those children at risk for poor care and poor asthma outcomes. He has developed an asthma specialist clinic for children, which he's going to go over today. His clinic incorporates clinical care, patient education, and clinical research. Dr. Okello's research interests include physician decision making regarding asthma treatment to the development of strategies to improve asthma care. Dr. Okello was also a principal investigator for one of our clinical pilots whose goal was to incorporate additional asthma management tools for children with high ACE scores that address both the toxic stress response as well as the presumed effect that response has on asthma outcomes. Thank you, Dr. Okello Sade, for taking the time to speak to our ACES LA community. We value your partnership and your wisdom. And without further ado, here's Dr. Okello.
Great. Thank you so much, Nina. Appreciate that introduction. Thank you, everyone, for taking time out of your busy day to participate in this presentation. I've tried to make sure there's adequate time to address your questions. As you know, one of the main opportunities is for us to have a conversation. I will not add, I think Nina covered all the highlights in the introduction, so we can go on to the next slide, please. So just so you have an overview of what topics I'd like to discuss with you today, we'll go into some background about kind of how common asthma is and some of the impacts, and take a closer look at what the diagnostic criteria are. Misdiagnosis or underdiagnosis is a common problem that it's helpful for us to review. And then we'll talk about what's actually in the NIH asthma guidelines and focus on one element of that, and that's how to use a validated survey to help better assess and then ultimately treat our patients. And then discuss or spend some time on the home environment and considerations of the impact of the home environment on asthma, and then, of course, end with a Q&A. So as many of you may already know, asthma is a very common problem in the United States. Between children and adults, about 25 million people are affected. A quarter of those are children. We have almost 1 million children in California and 200,000 in LA County that are affected by asthma. So very common. Anyone who deals with children is bound to deal with children with asthma as well. There's a number of different impacts that families experience due to asthma. It's the #1 cause of school absenteeism. About 60% of children will miss at least one day of school due to asthma during the school year. And then there are a lot of trickle-down effects in terms of the financial costs. So school districts lose money when kids miss school due to asthma. There are many emergency department visits for asthma, and this is more so in children. Despite only making up 1/4 of the asthma US population, children make up almost half of the emergency department visits, and they make up half of the hospitalizations. So children are more likely to have the negative consequences of asthma than their adult counterparts. And then I've already alluded to the financial impacts previously. If we take a closer look at asthma, particularly in primary care settings or settings where you all are involved, not only is asthma common, but it is commonly in an uncontrolled state. And in this study, they surveyed children coming to their primary care office to be seen for any reason. And then they surveyed those children with asthma to understand, was the asthma controlled or uncontrolled? And so across all visits, regardless of what the chief complaint was, about 46% of children with asthma had uncontrolled asthma. If the chief complaint was some type of respiratory complaint, maybe cough or wheeze, something like that, that went up to 54%. But even for children who had a non-respiratory complaint, maybe it was a headache or a stomach ache or something like that, 35% or more than a third had uncontrolled asthma. So in many ways, we should assume that if we have a child with asthma, it is very likely that they may actually have uncontrolled asthma, and that's an opportunity to intervene. The challenge is identifying those children, and we'll talk about how to use a survey to easily identify children with uncontrolled asthma. The importance of identifying uncontrolled asthma is that there are a lot of negative downstream impacts to the children and their families. In the same study that I showed you on the previous slide, they found that of those children whose asthma was uncontrolled, 2/3 missed school. Nearly half of parents missed at least one day of work. A slightly smaller percentage, 42%, had intense enough symptoms that they required prednisone, basically, to treat an asthma attack. And then just under a quarter of those children ended up going to the ER or urgent care because their symptoms were so poorly controlled. So it is really important that we identify not only the kids with asthma, but also determine if their asthma is controlled or not controlled so that we can prevent negative downstream consequences. So that's kind of an initial overview to set the stage. Let's talk a little bit about diagnosis, and then we'll talk about how to evaluate these children. So the diagnosis of asthma is what we'd refer to as a clinical diagnosis. And the criteria that are laid out by the NIH, which are fairly straightforward, but often not applied. And so many children who have asthma are missed in terms of having that diagnosis properly or correctly assigned. So there are basically three criteria that are laid out by the NIH, and I've put them here. It says to establish a diagnosis, we should determine first that asthma-like symptoms are occurring repeatedly or are recurring. And I've listed different symptoms here that can include coughing, wheezing, chest pain or chest tightness, shortness of breath, particularly with exertion, decreased stamina, particularly with exertion. Any one of these symptoms that occur in a repeated pattern would be consistent with asthma. Of these symptoms, the one that is easily the most overlooked is a cough, particularly a chronic cough. Many people are tuned to wheezing, but far fewer are tuned to cough, rather. Also, for these symptoms, they tend to occur under very kind of classic conditions or situations, most commonly with viral upper respiratory tract infections, exercise, and then the nighttime. So any of these symptoms that occur repeatedly that are either initiated or intensified under these conditions would be consistent with asthma. The second criterion is whether the symptoms improve with a course of asthma medication or a course of asthma treatment. And so what we're talking about is with use of the medicines that the patients report that symptoms last shorter, are less frequent, and or are less intense. The caveat to this criterion is that the medicines have to be given at an adequate dose for an adequate period of time and taken the right way. So that's the caveat, what I'd call an adequate trial of therapy. So if you're only taking, for example, one puff of albuterol once a day, that's not what would be an adequate trial of therapy, and I wouldn't anticipate that a patient's symptoms would improve with that. Okay, so just something else to keep in mind. And then the third and final criterion is making sure that other diagnoses or other possibilities are excluded. I have a few listed here. These are uncommon to rare. And like I said earlier, usually the biggest issue with making an asthma diagnosis is that people don't make it. Not that they do it too much, but they do it too little. And then last, as you'll see, age is not a criterion that's included by the NIH. Many people hear this mistaken idea that you can't diagnose asthma below a certain age. That's not correct. I've had patients who are under 1 year of age, patients who are toddlers, school-age teenagers, adults, and of course, on up to the elderly. Anyone can have asthma, anyone can develop asthma at any age. So we should no longer use age as a criterion in determining if a patient can be diagnosed with asthma or not. All right, so that's an overview of asthma statistics and diagnosis. Now we'll turn our attention to the asthma guidelines and actually looking at a tool that can be helpful in evaluating these children. So, if you're not familiar, the National Institutes of Health has been publishing asthma guidelines, which are basically panels of experts that get together. They review the evidence of published asthma research studies and offer their expert opinions. And this has been happening for more than 30 years. The most recent version of the guidelines came out in 2020. It is a great resource for information. There's a lot in the 2007 guidelines, which are also very useful as well. Okay, next slide. Um, Another resource that you may find very helpful, and I use this in my clinic, is this asthma medication poster. Over the course of time, there have been more and more medications that are being developed and manufactured for the treatment of asthma, and patients can be on any variety of medications. So this poster is helpful to me as a provider to understand what is out there. It's also helpful to have patients point out what medications they might be currently on or have previously taken. So a very useful tool. This poster version is 2019. There probably is a 2025 version that's available. I have a 2023 that I didn't include here, but 2025 version. And they come both 8.5 by 11 and 22 by 17. So definitely very helpful. So now let's drill down into what's recommended in the asthma guidelines, and that's how to use a validated asthma survey to assess, but also guide how patients are treated. So earlier, I mentioned that asthma diagnosis is one opportunity or missed opportunity that occurs fairly regularly. The next missed opportunity is also what I touched on earlier, and that's understanding if the child's asthma is controlled or not. They're very different treatment implications if the asthma is controlled versus uncontrolled. And so this is another opportunity to do right by our patients and understand specifically how their asthma is doing. I'll admit the challenge and the trick is how to set up a system so that each patient with asthma is getting surveyed. But since you guys have already extensive experience in surveying or assessing through your ACEs work, in many ways, a lot of the legwork for establishing such a process you've already done. And now would be the opportunity would be to add something on top of that. And then, at the end, I'll talk about maybe some creative ways that I'm starting to explore in terms of administering the surveys. Not necessarily in person, but remotely. So this is basically an asthma survey that I've used in my clinic for more than 10 years now. And every time a patient comes in, they fill this out. And it helps me greatly understand whether their asthma is controlled or not. It also makes my life easier because I don't have to remember every question to ask. Nor do I have to remember what all the response options are and how they line up to be used to classify asthma severity. So there are 5 questions here that ask about asthma issues over the prior week, and we'll go through those one by one. So the first question asks, over the past week, how many days has your child had asthma symptoms? For example, cough, chest tightness, shortness of breath, and so on. You see the other terms there. These are terms that patients told us that they are the terms that they use when describing their asthma. And so the response options range from 0 days in the past week all the way to every day, all day long. And you can see in this version, the response options are color-coded, and that's to make it easy for us as whoever's administering the survey to quickly identify whether there's a problem or not. And you can imagine any response in a green area is great, that's ideal. And then it gets progressively worse where any response in a red box is the opposite, that's not ideal. The second question asks, over the past week, how many days have you had to give your child medicine to quickly relieve asthma symptoms? For example, albuterol inhaler, spray, or pump. And again, it has the same choices as the question above. One can choose anywhere from 0 days in the past week to every day, all day long. Okay, the third question asks about attacks. Over the past week, how many days did your child have an asthma attack? For example, when it's harder for your child to breathe, when you give your child more asthma medicine, or when the asthma medicine does not work. And the options range from 0 days in the past week to 4 to 7 days in the past week. Activity limitation is the fourth question. Over the past week, how much has asthma limited your child's activities? And the response options range from not at all to completely. And then the fifth question asks about nighttime symptoms, and it's nighttime sleep disruption in particular. It says, how many nights did your child's asthma keep your child from sleeping or wake him or her up in the past 2 weeks? And the options range from 0 days in the past week to 8 to 14 days in the past week. Okay. Now, the answers to those 5 questions are used to classify the asthma severity. Yes. And so we'll see how this works shortly, but the controlled options, you have controlled asthma if all the options are green. And essentially you have uncontrolled asthma if any answer falls in the yellow, orange, or red box. And so the categories are listed there are mild persistent to severe persistent. Okay, so now let's take a look at how this survey would actually work. Okay, let's say that the patient reported symptoms every day, all day long. Reported 3 to 6 days of rescue medication use. Reported 2 to 3 days of asthma attacks in the prior week. A slight degree of activity limitation due to asthma, and 1 night of sleep disruption. So the way this survey works is based on what the guidelines advise us, and that you classify asthma severity based on the most severely or the worst reported symptom. And so if we look at the top question, the first answer is that they were experiencing symptoms every day, all day long, and that's why they're assigned severe persistent. Okay, so this is the goal, ideally, of when we see a child with asthma, whether it's for a respiratory complaint or not, that we screen them with this simple tool that's very quick and easy. Patients can fill it out themselves. And we can quickly get an answer. Now, as I said, this is the next goal, is to determine if the asthma is controlled or not. And as I mentioned, the patient or parent can complete it in the waiting room or the exam room. Ideally, they complete it at every encounter. And there are a variety of settings that this survey has been used in: clinics, urgent cares, EDs, hospitals. So the range of settings are varied next. And it doesn't necessarily have to be the provider who administers the survey. A range of different people on the healthcare team can administer the survey. So you can incorporate into your intake process somewhere along that workflow to administer this. And I would say lack of use of such a tool risks not accurately assessing asthma control, and most simply determining if the asthma is controlled or not controlled. And really, if the resources or the situation doesn't allow you to systematically incorporate this, that you consider having a lower threshold for referring to see a specialist. And then last was that you can use this information to help set the stage for how you will treat the patient. So we'll go through about 4 slides that show examples of that. You've seen the patient. When would they start their rescue medication, their albuterol? Okay. If they have any single answer that falls in a yellow, orange, or red, they all don't have to fall in there. Just one needs to fall in there. Okay. Okay, and once we determine they have uncontrolled asthma, then the guidelines suggest that they follow up in 2 to 6 weeks to confirm that the asthma has gotten better in that period. Well, how about when an asthma patient should come back for a reevaluation? Just like we saw in the previous slide, if they have uncontrolled asthma, follow-up is recommended to occur in 2 to 6 weeks. However, if they have well-controlled asthma, follow-up can be in 2 to 3 months. So you can see how the recommendations differ greatly simply based on whether their asthma is controlled or uncontrolled. So you can see it is important to help make that determination accurately at the time we're seeing the patients. Well, how about when to start a daily controller medicine? Again, they have any level of uncontrolled asthma and they're not already on a daily controller medicine, then this would be an opportunity to start that. And then, of course, follow up in 2 to 6 weeks to determine if the controller medicine that you prescribed is actually taking effect and that the patient no longer has uncontrolled asthma. How about when to start oral steroids? The guidelines suggest that anyone with moderate or severe persistent asthma is a candidate to be treated with oral steroids. And really, what this means practically is that many of these patients are patients that you see routinely in clinic. They're not hypoxic, they're not in respiratory distress. They most times do not look like patients you would send to the emergency room. Yet they're experiencing significant burden from their asthma. They're having symptoms daily, or they're requiring their rescue inhaler daily. They're having 2 to 3 days at least of asthma attacks. They're having significant activity limitation due to asthma, very much or completely. And then there is a frequent sleep disruption due to asthma, at least 3 nights out of the prior 2 weeks, and it could be more. And so, our goal as healthcare providers is to identify and quickly address these issues. And so, proper and accurate screening can help us better identify these patients. Okay, and then of course, if they need oral steroids, follow up in 2 to 6 weeks would be recommended as well. I know through firsthand experience that putting the system in place to make sure that every patient gets screened can be burdensome. It is a commitment. So I don't say that kind of casually or lightly. And I realize that that may not be able to be replicated in every setting. So I more on kind of the research side, I began to explore, hey, is there another way to get the survey to patients that might be easier and less burdensome? And so through a couple projects, I've explored text messaging this asthma survey. The PATCHY is the acronym. What I'll share with you is a little bit of information on a study where we did it following an emergency department visit for asthma. Here's just a screenshot of what the patient might receive in terms of what the format looks like. Hi there, are you ready to answer a few questions about your child's asthma? Yes. And then it begins. Great. And so there's some additional, this is one of the additional questions I didn't include in the presentation, but otherwise it's essentially what you saw previously in the earlier slides, just in a text message format, and they can respond accordingly. In the study I'm about to tell you next, we did this actually for a year after the ER visit. And I would say in general, it was pretty well received. We actually sent this survey out by text message every 3 weeks for a year after the ER visit. And so what I'm sharing here is what the response rates were by those people who were involved in that study. And I have just the first 3 months of data. It leveled out at about this. It stayed at about 50% for the rest of the study, the rest of the remaining 9 months. And so I think there are a few ways, at least, that I view this. One is it was a doable way of surveying patients. That was the first question that we needed to answer. Second is that people would respond. You see it 3 weeks after the ER visit, we had 78% response rate. I mean, yes, it went down, but if you look in the literature in terms of follow-up from an ER visit, people going back to their primary care, that's on the order of 30%. After an ER visit from asthma, only about 30% of patients follow up with their primary care. So 78% or even 54% is very good. Third is we could consistently keep people engaged over the course of the process. Like I said, every 3 weeks was very frequent, more frequent than I could ever see a patient. But I think it's mostly good news that I think families saw some value in this. With the text message, we would automatically feed back information to them. Any self-reported non-adherence, we'd offer strategies to improve adherence. We would automatically feed back what their asthma severity or their control level was. And then based on that severity or control level, offer some preliminary recommendations about what they should do. So kind of an automated asthma action plan all through their phone. I was really excited about this. This study was done out of Children's Hospital Los Angeles. It was about 80 or 90% of the participants were on Medi-Cal. About 20 to 30% were primarily Spanish speaking, and about 80 to 90% were either Black or Hispanic. So, populations that tend to be undertreated for asthma and also tend to have worse outcomes, meaning like more ER visits, more hospitalizations for asthma. Um, uh, I could go on and on about this, but in general, I just wanted to share this snapshot with you. Okay, so we've reviewed use of a validated asthma survey to guide treatment, and hopefully that gave you some insight. Hold on to your question. I know there's a question where I definitely made sure that there's time to answer questions, and I will circle back to you. This is a slide that I showed earlier, and it highlighted how common uncontrolled asthma was among children coming to primary care for any reason, whether respiratory or non-respiratory. For providers, identifying uncontrolled asthma is a big and important step, and we've seen that as well. One of the next steps is to understand why the asthma is uncontrolled so that you can tailor your treatment plan accordingly. Whenever I have a child with uncontrolled asthma, there's 6 basic reasons that I go through to understand why their asthma is uncontrolled, and I've listed those here. So non-adherence, so inconsistent use of medication, poor inhaler technique, maybe they're not using a spacer at all, or they're using it improperly. Environmental exposures, we'll talk about this a little bit more, but the 2 big ones would be tobacco smoke exposure, and then allergens that they're actually sensitized to, and we'll touch on that briefly. Intercurrent illness, basically an upper respiratory tract infection, probably the most common cause of uncontrolled asthma. And then comorbidities such as hay fever, obesity, or sinusitis. And then last is undertreatment. So I don't necessarily expect you to kind of remember all of these all of the time, but just trying to offer context for how to think about why a child has uncontrolled asthma. And then for the purposes of today, we'll touch on a little bit more about environmental exposures. Okay. So as I mentioned briefly, when we talk about environmental exposures and asthma, we're really talking about kind of 2 main things: environmental tobacco smoke exposure, and then indoor allergens, indoor exposures. And I've listed just a couple of examples there: dust mites, cockroach, there can be others, pets, cats or dogs, mice, are a few of the considerations. But really, from an asthma standpoint, exposure alone is not enough. The child or the patient actually needs to have an allergy to the exposure, an allergy which we would call sensitization. And so being exposed and allergic is the combination that's necessary in order to result in asthma symptoms. Okay. And then I have a quote here from an article that I'd come across. It said, children with asthma who are allergic and exposed to indoor allergens have worse asthma control and lung function and greater airway inflammation and morbidity. So basically what I've said there up above. Before we implement any kind of changes in the environment, we need to identify if the child is allergic to it. Before that, if there's an opportunity, we can screen for exposures, and then if there are exposures, see if there's allergy to it. So one way that I screen in my clinic is actually just through a questionnaire. Next slide. That asks patients about kind of their housing situation. And so, yes, you can stay there. So, kind of the type of housing, kind of exposures in the house, whether it's type of heating or damp areas or plants or cockroaches or anything. I ask if they have dust mite exposures possibilities in the child's bedroom, such as wall-to-wall carpets or stuffed toys. And then, do they use any protective barriers against dust mites? This is all part of the screening process. And then I also screen for smoking as well. And then smoking rules are up at the top. Do they allow it in the house? Never, sometimes, all the time. And then who are the smokers in the household that live with the child? Okay. And then another way that I get at understanding if there's an impact is understanding, well, what triggers to initiation and or intensification of symptoms does the parent recognize? And so there are a variety of conditions or exposures that are listed here that I ask parents to say, hey, this is something I recognized intensifies my child's asthma. And I have, for example, a tobacco smoke listed there. Okay. And I'm just going to highlight a few of the relevant ones. House dust mite, molds, tobacco smoke, fumes or perfumes, pets, okay, are just a few examples. Now, house dust mites are one common allergy that children with asthma have. Exposure is based on the screening, and then we would do allergy testing to identify if there's an actual allergy. And then if so, then we can implement these exposure control measures. And so it might be the dust mite proof bed and pillow covers, washing sheets and blankets in hot water to kill the dust mites, or if in cooler water using detergent and bleach. Keeping the environment dry is harder for the dust mites to survive. One could potentially go so far as to remove carpets in the bedroom. That's a rare instance in my experience. Avoid sleeping or lying on upholstered furniture where the dust mites will collect and which is harder to clean. And then minimize the stuffed toys, at least that are on the bed, where children are spending 8, 10, 12 hours of the day during sleep, and wash those weekly. Those are just a few strategies one can implement. And these strategies in those who are exposed and allergic can have positive impacts in terms of improving asthma control. And that's highlighted on the next slide. With environmental control practices, patients experience fewer symptom days per year, fewer missed school per year, and fewer acute visits as well. But again, it's important that you identify not only the exposure, but also what they're allergic to before implementing any environmental control practices. Okay. So, this sums up what I wanted to touch bases with you today. I tried to kind of approach this from some different angles, but cover, a broad range of topics, but more importantly, leave time for lots of question and discussion. So, we can go to the next slide, and that wraps up my presentation. So, I will turn it back over, I think, to Nina. I think you're going to lead the Q&A. Is that right?
So first of all, Dr. Okello, thank you so much for your presentation today. So informative, and we really appreciate you being here today.
Thank
Uh,
you.
I would I would like to open it up to our audience. If you have any questions, please feel free to drop them in the chat or raise your hand. And we can start off with Patricia, who has put one question in the chat. Dr. Okello, Patricia asked, she said, asthma is not diagnosed in children younger than 3 years old, but upper respiratory infections in infants have been instead of asthma. Is this correct? Or
Yeah, I think that's a great question, Patricia. I think it depends on the pattern of symptoms. And so if we who's controlling the slides? If we can go back to the diagnosis slide, it's 25 slides back. You can, yeah, go through rapid sequence. Yep, keep going. Okay, next. Yes. So I tried to kind of simplify these criteria, but is the child having repeated or persistent cough that lasts, for example, longer than a month? Are they having repeated episodes of wheezing? These are most often going to occur in the context of a cold, but that doesn't mean the cold and asthma are mutually exclusive. They can definitely coexist, and as we talked about, URI is a trigger. So for the child who coughs for kind of 2 weeks with every illness, has wheezing with every illness, is coming to seek care. I think there is, a missed opportunity to diagnose that child with asthma because that is the gateway to putting them on proper treatment. Um, I didn't talk a lot about treatment, there's a lot to talk about, but the first big step is assigning the diagnosis. Um, I would say it's I'm a specialist, so I deal with different conditions, but I've very rarely encountered overdiagnosis of asthma. Certainly there can be patients who are mistakenly diagnosed, but that tends to be the exception more than the rule. Um, if I could add on, I know there were questions submitted kind of prior to this, and someone asked about smart therapy. For those
yes.
of you who don't know, smart therapy is using a single inhaler both as your maintenance and rescue treatment. Um, so we're talking about two medicines in particular that can be used this way, Symbicort and Dulera. They're the only two medicines really kind of shown to work this way. And so, for example, you might have a patient taking 1 to 2 puffs twice a day as their maintenance, and then at the time of a cold, you could boost that to 4 puffs 3 times a day until the cold is over. It is a very effective strategy, but with the increase in puffs, you are likely to kind of accelerate consumption of the inhaler. And so the challenge that I've run into is with insurance that if patients consume their inhaler before 30 days have elapsed, they're often not allowed to refill that medication. And so I've had to shy away from using smart therapy. Now, this varies from provider to provider. I believe you guys are in a closed system. So there may be allowances, for example, to get 2 inhalers dispensed at a single dispensation, and that way a patient can implement this therapy. Obviously, I didn't have time to really drill down on smart therapy, but I know that was one of the questions. So I just wanted to
Yes.
tag that on to the previous question.
Yes, and thank you for addressing that. Would you say that is good for ages 5 and up, 5 and over? Is smart therapy something you'd recommend?
Yes, absolutely.
Okay.
Yeah.
And that same within that same question, they did ask a little bit about ICS and SABA.
Oh, yes, yes. Thank you for that. And what I should do, the question was, are you using smart therapy for ages 5 and above, or do you prefer ICS plus ASABA, which would be short-acting beta agonist? I both are great options. So I think you have to deal with the hand that you're dealt. If the insurance will allow dispensation of inhalers before 30 days, like multiple inhalers before 30 days, then smart therapy is a great way to go. If that is not available to you, then the traditional approach is great. And what I often tell parents, particularly about the short-acting beta agonist, which is albuterol, is that many parents worry about giving too much albuterol, but they need to worry about not giving enough. So I encourage them to give it 4 times a day. And I tell them the range of puffs that they give is 2 to 8 puffs per treatment. So again, under treatment is the challenge most parents face, and I'm encouraging them to use it frequently and regularly. So thanks for reminding that,
Mhm.
Julie, about
Thank
the
Oh,
full question.
of course, thank you for your answer. We do have quite a bit of questions going in. So the next question that I wanna address is from Tan. What are the highest yield environmental modifications that you see with patients who have Medi-Cal? Often, my patients don't have much financial ability to replace carpets, drapes, mattresses, etc., assuming that the patient is indeed allergic to the dust mites and those environmental cues.
Yeah, and I'll take that assumption to be kind of in this hypothetical, because again, we do need to absolutely improve it before we embark on these measures. I think that it's been I've had patients come to me where they've already pulled up the carpet, but it's been rare that I've asked people to have to do that. The dust mite covers, bed and pillow covers, I think are very high yield. Um, and because the kids spend so much time on the bed, particularly with sleep, and probably less time on furniture or on the carpet. Also, I talked about removal of stuffed animals from the bed. They can be in other parts of the room, but removal from the bed. And then washing the stuffed animals and the bedding in hot temperature if possible, otherwise bleach to kill the dust mites. I think those are reasonable strategies. I hope those are reasonable that people can implement on their own, that don't kind of require the intervention of a landlord, so to speak. So hopefully that answers your question.
Okay, thank you so much. The next question is from Olivia, and says, "I was previously told that Flovent has been discontinued in the U.S. What are other options?"
Yeah, I think what happened with Flovent is that the patent expired. And so it is available. There's quote unquote generic Flovent and brand Flovent. And really, the issue boils down to kind of what's on the formulary of the health plan provider and what they're willing to cover. But if we look at the poster, can we go forward a few slides? Next, one more. Yep. So back. Yep. So if you look in the second row, it has inhaled corticosteroids, and there are lots of options that are there. And then if you add in the combination medicines that are under the green banner in the third row, we have even more options. So Asthma-Nex, in the middle, the blue inhaler. It comes in 2 versions, but I'm highlighting the blue inhaler is a great alternative. I think with the shift in availability of Flovent, it's probably put more demand on Asthma-Nex. Um, QVAR is good, but it is a self-actuated inhaler, so I tend not to use that in children under, say, 9 years of age, because they tend not to be as coordinated in using a self-actuated inhaler. And so there are lots of kids as first-line therapy. I'm using Dulera and Symbicort. I think they're great, and if that's on the formulary of the health plan, then I'll go with that as a great option to start their treatment with. So you have a variety of options to use other than Flovent.
Okay, thank you so much. Another question that we got in was from Maggie, and she's asking, is it useful for inpatient providers to change a patient's asthma regimen upon discharge or allow the primary care provider to handle?
Yeah. I think that's an excellent question, and I'll try not to give too long-winded of an answer. But for every admission for asthma is a failure of outpatient therapy, whether it's due to underdiagnosis or the 6 causes that I listed there. So let's fast forward towards the end. Let's do a rapid sequence of the slides towards the end. And there's a list of 6 causes of asthma. Well, while we're happening, what I'm getting at is, well, why did the patient end up in the hospital? So was it underdiagnosis? Were they not diagnosed with asthma? Was it under treatment? Were they on no treatment or inadequate treatment? I think depending on if the answer to those questions is yes, then I think it absolutely behooves us to initiate or alter the treatment before discharge from the hospital. After all, our goal is to prevent this reoccurrence from happening again. If you look at asthma guidelines, you get one free pass for oral steroids every 12 months. So what our objective in setting up our treatment plan at the time of discharge is, what do I need to do to prevent this patient from having another asthma attack that will warrant oral steroids again for the next 12 months? Okay. And I think it's on the one hand, it doesn't seem like a nuanced idea, but on the other hand, I see it all the time that it's not addressed, that patients leave on the same medication plan that they entered on. Well, we need to give, if possible, some thoughtful consideration as to why the patient ended up in the hospital, and then address that in the treatment plan that we set up at the time of discharge. Um, uh, I think I've only really rarely encountered a turf battle, so to speak, if you will, about kind of like initiating treatment for this patient. Other factors, this is getting probably into more nuance. I try and look at, well, what is the relationship of the patient with the primary care provider? In other words, how often are they seeing them for asthma? Are they seeing their primary care provider once a year at their well child visit and that's it? Well, if that's so, then that is a void that I should kind of step into it and address, and not assume that it will be taken care of by their primary care provider. Yeah, that slide right there. Okay. Probably not the situation that's being brought up here, but when I'm in the hospital, sometimes they're patients who live far away. They're like 3 hours away. I don't know what their situation is going to be for follow-up, so I can't bank on the right things happening. And again, I circle back to, well, why did they end up in the hospital? So hopefully that is a helpful response to your question.
Okay, thank you. The next question is from Sonal. Any advice that you can give the audience who may have patients that have landlords who refuse to change air filters, to refuse to address mold or other potential triggers?
Yeah. Again, not to be a broken record, I think, first is identifying whether the child actually has an allergy. And so that's doing the allergy testing. Um, and then second, targeting what the triggers are. There are things, for example, trees and grasses that, are difficult to control. And so I think it depends on the situation. Mold, that can be a tough one. But I think the first step is identifying that the child actually has an allergy to mold. Which in my experience is probably one of the less common allergies that people have. The air filters, those really ultimately are probably not of much benefit from an asthma standpoint. And then other potential triggers, it depends what they are. I think there's some things that, obviously can fall under people's control. Tobacco smoke exposure, if it's in the home, if it's neighbors, that's a little bit harder. So I don't know all the resources available to patients. I know that's a tough one, particularly if they don't have the resources or the readiness to move. I know in some settings there is legal resources available. I'm less connected with that here in LA than where I was previously in Baltimore. So a tough situation, but I think the specificity of the allergy. I think someone's putting something in the chat to help answer this, but the specificity of the allergy can help guide what people can take on themselves versus what they need from others.
Yeah, I think Lucia is offering to consider MLCP for housing advocacy for DHS patients. So looking for some advocacy for the housing. I would also recommend maybe going to the public health department and seeing if there's resources there, um, to see their local public health department, to see if there's anything about molds, or there's other agencies. But thank you, Lucia. I appreciate that. And Olivia says you can file a complaint with the LA County DPH, Department of Public Health. So
Thank you, guys.
thank you, everyone. Yes. We are getting close to the end here, but I want to take a few more questions if we have them. One is, do you have any resources that you can share? Maria has asked about asthma teaching resources. Any
Yeah.
teachers?
Yeah, if you go to our UCLA website, the UCLA Pediatric Pulmonary website, we have a number of educational resources, inhaler technique, both with a nebulizer and a spacer mask. All of that instruction is on there in English and in Spanish. We also have an educational cartoon called Huff and Puff that I think is also available in English and Spanish, just to give some basic education around asthma. And then there are some webinars for parents. These are recorded webinars that people can watch on the diagnosis and treatment of asthma. And while I'm on that, I know someone asked about nebulizers versus inhalers. I think either is a great option. It's a matter of whether they're taken properly. So if the nebulizer, they need to wear a mask or use a mouthpiece. They can't use blow-by. Otherwise, the inhaler with a spacer or spacer and mask is a great option. What I alluded to earlier, people need to give enough puffs of the albuterol inhaler for it to be effective, and under dosing is the biggest issue with albuterol inhalers. Again, 2 to 8 puffs per treatment, 4 times a day. And so these higher 4, 6, 8 puffs of albuterol will be equal to the impact that people see from the nebulizer. At the end of the day, it's mostly a matter of what can the child do with the most proper technique is the way I would go. So, okay.
Thank you. Okay,
Yeah.
we have one last question. When you think about patients who are experiencing trauma or have identified ACEs, how do you guide them in managing those experiences concurrently with a diagnosis of asthma?
Yeah, yeah. I think from the asthma standpoint, I certainly try and get creative. A couple of basic ways, just in terms of burden on the family, try and simplify the regimen, do once a day dosing. For any of us, 2 or 3 times a day can be a challenge. So I'm talking about the controller medications. Um, I've also tried to utilize the schools for assistance in terms of medication administration, just as a way of decreasing the burden from the family. If the kid can get their medicine at school for 5 days a week rather than 1 or 2 days a week, that can also be helpful as well. For most schools and even daycares, in my experience, they're willing to do that. There may be a form that needs to be completed, which, I know can be a challenge as well. But there is a way that can be done. On the ACEs side of things, I probably defer that to some of the expertise that's here, Nina and others that, are more in that setting about kind of dealing with the ACEs side of things. But I do know with, those issues at play that, there's a higher risk of kind of symptoms and uncontrolled asthma. And so I certainly try and do what I can in terms of properly identifying, if the asthma is controlled or not, and then making sure that the treatment is doing what it can. So, okay.
I want to thank you again, Dr. Okello, for such a thoughtful, informative discussion and presentation, and our audience too for all your wonderful questions. If your question hasn't been addressed, please let us know. Send it to us and we will get it answered by Dr. Okello.
Yeah,
We're
totally.
Yeah, we're running out of time, but thank
Yep.
you. We have a couple announcements. Next slide. We have our social media. You can follow us on our Instagram at aces.la, and we would love for you to follow us. We also have our web page where you can find this webinar and many other valuable resources for your patients, and that is aces-la.org. And our next Lunch and Learn is going to be on summer resources across LA County for across all spa areas in LA County. And that is going to be held on Wednesday, April 16th from noon to 1 p.m. So we would love to see you all there.